Hello, I'm Dr. Matthew Krafft of West Virginia University Hospital, and I'm here to discuss an original article out of Thomas Jefferson University Hospital by Dr. Tina Bortolari et al., featuring Principal Investigator Dr. Faisal Kamal. The article is entitled "The Success of Different Closure Modalities of Gastrogastric or Jejunal-gastric Fistulas After Endoscopic Ultrasound-Directed Transgastric Intervention," or EDGI for short. This was a 6-center retrospective study featuring colleagues at Thomas Jefferson University, Fife, Hackensack, Wake Forest University, West Virginia University, Henry Ford, and Weill Cornell. First, some background. Roux-en-Y gastric bypass is the second most common form of weight loss surgery in the United States. Over 63,000 patients have undergone this surgery. Gastric bypass anatomy presents a unique anatomical challenge for advanced endoscopists seeking to access the gastric remnant and/or the pancreatic biliary limb. Historically, this feat is only accomplished using deep enteroscopy, surgery, or IR. In 2014, EUS-directed transgastric ERCP EUS, or EDGE for short, was described by the Cahala group. Over the next 10 years, there was widespread adoption of this procedure, and advanced endoscopists began performing transgastric interventions other than EUS-ERCP, which led to the term EDGE, or EUS-directed transgastric interventions. So, what is an EDGE? EDGE involves EUS-directed deployment of a lumen-opposing metal stent, or LAMS, to fistulize either the gastric pouch or proximal jejunal roux limb with the bypass stomach. This reestablishes continuity of the alimentary canal. Subsequently, any anterograde transluminal endoscopy can be performed in the bypass stomach and/or the PB limb. EDGE is subdivided into 3 stages, which are performed at varying intervals depending on the clinical malady at hand. Stage 1 refers to fistula creation via LAMS deployment. Fistulas can be gastrogastric or jejunal-gastric. Stage 2 refers to the transgastric intervention, such as the ERCP. Stage 3 refers to LAMS removal, of course after fistula maturation, which is widely thought to be about 2 weeks after LAMS deployment. In the year 2025, the biggest questions surrounding EDGE or EDGE are: 1. Should we close the GG or JG fistula? And 2. What closure modality is most effective? With this background in mind, we will now turn our attention to the manuscript by Dr. Bortolari et al., which seeks to help answer the question of post-EDGE fistula closure technique efficacy. So, a little bit about the methods. In the present study, 106 patients were retrospectively identified across 6 teaching hospitals. Each patient underwent EDGE and then had a follow-up study to assess for persistent fistula after LAMS removal. 90 patients had 20 by 10 mm LAMS, 16 patients had 15 by 10 mm LAMS deployed. At the time of the LAMS removal, 86% of patients had primary endoscopic fistula closure, whereas 14% of patients had spontaneous fistula closure by secondary intention. This means the LAMS was removed and nothing was done to close the fistula. For those that did have their fistulas closed, the most frequent form of fistula closure was APC plus endoscopic suturing using the overstitch platform. 42% of patients underwent closure using the modality. The second most common form of primary fistula closure was APC plus through the scope clips. 17% of the study cohort underwent this closure modality. The third most common form of fistula closure was doing nothing at all. In other words, spontaneous fistula closure by secondary intention. This was the modality of closure in 14% of patients. The fourth most common closure modality was endoscopic suturing alone, which was performed in 12% of patients. After LAMS removal plus or minus primary fistula closure, patients either had an EGD or an upper GI series to assess for persistent fistula. These studies were performed a median 41 days after lamb's removal. Persistent fistula occurred in 21% of the overall study cohort. So let's break it down by fistula closure method. Overstitch alone had the highest rate of persistent fistula at 46%. Spontaneous fistula closure had the second highest rate of persistent fistula at 27%. APC plus overstitch had an 18% rate of persistent fistula, and APC plus through the scope clips had a relatively low persistent fistula rate of around 6%. On univariate analysis, there was no difference in persistent fistula rate in those who underwent primary fistula closure versus those who underwent spontaneous fistula closure. Additionally, neither lamb's diameter or fistula route, whether it be GG or JG, were associated with persistent fistula. On binary logistic regression, lamb's dwell time was the only positive predictor of persistent fistula with a p-value of less than 0.01. In other words, when adjusting for lamb's dwell time, there was no difference in persistent fistula rate amongst the three most common closure modalities compared to no closure at all. So what are the take-home messages of this study? Lamb's dwell time was the only variable that influenced persistent fistula rate on multivariate analysis. So what this means is if you want to minimize the risk of persistent fistula after edgy, you should minimize the dwell time of the lambs. Interestingly, primary fistula closure after lamb's extraction did not help reduce the risk of persistent fistula, no matter the closure modality. Thank you for tuning in.